All right. Oh, yes, past time. Okay. Well, welcome everybody. Thank you for joining us today to learn a little bit about North Carolina and what we did in our COVID response. One of the things that we actually did quite a few things, but I want to start with a little bit of news, just because we should always honor and highlight some great leaders in our country. Our Secretary, Mandy Cohen, just announced that she's resigning today. She's resigning at the end of December. But you're going to see a platform that we all worked on that was really, from a strategic perspective, really came from her mind. Not necessarily the nuts and bolts of it and how we got there, but the desire to be transparent, the desire to open up a data communication with our residents of North Carolina, as well as to set us up to handle good quality data to make real decisions that impacted millions of people's lives during the COVID experience. So I do want to highlight that to begin. We're very bittersweet. She's worked burn candle at both ends for now about 2 years, and she's been with us for 5. So it's a pretty big deal to have a secretary last that long. So we're really excited about her, but just wanted to lift that up as something to kind of remember as we're moving forward. So as everyone has experienced, we were all kind of hit with a blow, I'd say back in March of 2020, we received our first confirmed case of a gentleman who had flown in from Washington State. You remember that was the first place it landed, that we knew about at least. And from that, COVID spread like wildfire. And for the next period of time till now, we're even still dealing with it in North Carolina. But one of the guideposts that we had was to establish a really healthy way to communicate with our residents of North Carolina. As you know, there was a lot of noise. Not all of it was consistent coming out of the federal government. But our governor, Roy Cooper, and our secretary, Mandy Cohen, put out the guidance to all of us that we needed to step up our game on our technology platforms. We needed to make sure that we are doing the best we can to move things forward, and that we were doing everything we could to be transparent with our citizens. Because as you recall, it was a very scary moment. I mean, to a degree, it's still scary. But at least now we have the vaccines. At least now we know some of the protocols to follow to make life a little bit safer. But back then, we just knew so little. The big thing for us in North Carolina was when the ACC tournament, basketball tournament, actually closed. That's when you knew it was real and that we had to get to business. So with that in mind, we all took our positions very seriously. My name is Charles Carter, by the way. I am the Assistant Secretary for Technology Services for Department of Health and Human Services. Work closely with some of our DIT partners. We work closely with a lot of our exterior partners. We had a lot of great partners. 2 of them you're going to meet a little bit later on. But I need us all to make sure we're focused on where we were back in that time period, because what you're going to see is an evolution of sorts. We were focused on these early stages of dealing with a very unprecedented global challenge. We needed to communicate with our citizens. We needed to communicate with our residents. We needed to make sure that they had the best information that they could have, and that it was real time, just so they could know what was going on. As you can see, some of the reporting data that we have here, you can go on the North Carolina Department of Health and Human Service website today. You'll see those same graphs, same visual analytics that are representing each of those categories up there, from case counts to county transmission data, vaccinations, so on and so forth. We've got things down to zip codes. We have to be careful, obviously, with suppressing data to make sure that we're doing it correctly and not exposing anyone. This is very sensitive data, so we have to make sure that security is woven through all of this. You'll hear a little bit more about that. But as you can see, our guidance was to make sure that we were using data and science to guide all of our public policy decisions, and to help empower people to deal with their own decisions as going forward. So one of the key challenges, and you'll learn a little bit more about how we solved that, was dealing with very old, very arcane data sources. We were actually, I'll give you one example of that, with our lab reporting. We were actually receiving faxes Our legislator demanded or put out the law that not only did we need to receive positive lab reports, but we also needed to receive negative. So you can imagine we went from 0 to 100 pretty fast there by just getting a significantly large amount of data coming through. And a lot of it was faxes. So we had a lot of unstructured data that we needed to figure out how to put into these types of dashboards that we had for everyone to see. So with that in mind, I'm going to turn it over to Ed Fody, who was represented Accenture. We worked very closely with Ed and his team going forward. So Ed?
Thanks, Charles. Like Charles said, my name is Ed Fody. I'm an associate director with Accenture. I've been working with the state of North Carolina as a client for going on 12, 13 years right now. So I have a lot of experience with the department, a lot of experience with some of their platforms. So like Charles said, we had a problem. And I'll give all the credit that's due. It was really the AWS local team, Charles's team, who within DHHS, and some other partners as well, who sort of helped think through how to stand this platform up, what the right technology was, and then actually deploy it and implement it pretty quickly. But sort of going back to the platform, we had to figure out really quickly what we needed to actually capture and manage all this COVID data that was coming in. You can imagine all the bed count data and all the mortality data and all the cases and testing data all coming in very quickly from a lot of different sources. We had to sort of figure out a way to manage all that data quickly. And the answer came up to be Redshift. And the reason we picked Redshift was, like I said, it's a lot of tabular data that was coming in, statistical tabular data. Redshift as a data warehouse is a pretty familiar pattern to the department. The department runs 2 large data warehouses, one for Medicaid and one for other business. So having that type of structure in place was very familiar to the team that would be running it. And then also, we're going to be doing a ton of reporting out of this thing. So we had to figure out a way to put this warehouse in place such that we can actually pull information out of it. And that information was going to a number of sources, including media, internal for the governor and Secretary Cohen to make decisions around what to do next, all those types of things. So we had all this data coming in, so it just sort of made sense that Redshift was the right answer for the time. There's also a lot of abilities with Redshift around clustering and scaling and things like that that are sort of inherent to the product that were attractive as well. So we could multi-region it, we could do other things with it to make sure that that platform was redundant over time. We also evaluated a number of other products, RDS and Aurora and things like that, but again, we sort of kept on circling back to Redshift as the platform. We also, as you see on the picture here, we have a couple other products that we surrounded it with. Boomi for integrations and API management in and out of the platform. Go Anywhere for MFT. We do a ton of MFT because a lot of this information is coming in CSVs and Excels and different file formats. We have Tableau for actually visualization and presentation of the data. And we've gone through a number of flavors of Tableau. We started with a Tableau server that the state had on-prem. And I think the first time we published a report, it got 30,000 hits in like the first 6 minutes and just crashed, it just melted. So we had to move over to Tableau Public, their SaaS offering, and actually post the reporting there so we can actually present it on our website without, with some level of assurance that it would actually perform. And on the left, we have a couple products around Glue. We used a lot of Tableau Prep for ETL purposes. And then you also see, again, their data pipeline and MFT for AWS for SFTP transfer. We use primarily MFT for that purpose. And then and you'll hear a little bit about this from Matt in a few minutes. The state's sort of starting to evolve that platform now and start thinking about other products like Athena and Aurora, unstructured data within S3 and other places like that to kind of evolve that platform now that it's sort of been in place and operational for, going on almost 2 years. So deployment weekend, and we call it deployment weekend because it was literally a weekend. Again, the department worked with the local AWS team, their internal data scientists, a couple of who might be here today, to kind of figure out the platform, came to a decision, and then on Friday, and deployed it over the weekend and had it up and running and receiving data on Monday. And that the tool really allowed the department to go from sort of like what I call purposely lethargic, right? It's a large, 30,000 person department $20 billion budget, big organization, and it has sort of lethargic processes built into it. But when we put the platform in place, it allowed the department to be much more nimble. We could take in data from different sources. And again, we all remember March 2020. Those data sources were changing like on a daily basis. We get new data types, we get bed counts, we get ventilator counts, we're adding hospitals, all these different organizations who are sending data to the state. And Secretary Cohen was very focused on transparency and trust. And again, as we published this data and people saw it, and I remember one specific day where the test numbers went up by 1,200 more than they had like the previous 5 days. And there was a lot of focus on trying to make sure that we were being transparent about why that happened so people could trust that data, because there was so much misinformation flying around at the time and people were really trying to understand what the real situation was. So having that, that reporting to be accurate and transparent and explainable was really important. But it was also fast. The media would call us at 11:45 in the morning if the website wasn't updated and they couldn't pull down those reports. So having that, being able to get that out quickly on a daily basis, accurately and explainable, was really important to the department. And then some of the reporting you see here. So once we deployed it, I think Charles, to his credit, and the department, the division of IT within the Department of Health and Human Services, had the foresight to say, well, this thing is out there. We should do a little bit of an assessment around it to make sure it is compliant with the HIPAA rules and regulations, because it had PHI and PII resident in the database, and also make sure it was secure. So again, it was stood up over a weekend in a public health emergency, so we want to make sure that no corners were cut from a security perspective. So we did perform a HIPAA assessment on it, went through all the HIPAA rules and regulations, made sure that all the data was compliant. Also went through the security pillar of the well-architected review, the AWS well-architected review, went through the whole security pillar, made sure everything was structured as it was supposed to be. We also used a number of pre-built components from the Department of IT, a sister department, that included the internet gateway, firewalls, monitoring, things like that. So we knew we had a secure front end, and we went back and through and made sure that the warehouse and the structures in the back of it were all secure. I will tell you that at the time, the amount of traffic the department was getting was unprecedented. We had more hits on the website in the month of March 2020, about 18 million hits, unique hits, than the department had in the prior 2 years. So making sure that, and they were coming from all over the place. So again, making sure that it was secure, the data was trustworthy, and that we were complying with all the regulations and rules that we had to, was again important. So then we thought about, so now we have a secure platform. We have a platform, it's secure, it's HIPAA compliant. Now all of a sudden we have all these data sources flowing in there. And we had to think about, all right, well, how do we control this stuff, right? So we're bringing in tons of data sources on a daily basis through APIs, through files. How do we actually make sure that we are managing this data as it comes in? So we put in some quick and dirty governance. And you can sort of see the flows we actually put together on the fly, on the phone at the time. And the second we put this governance in, everyone hated it. And it was very tactical in place. It wasn't what I would call long-term, well-thought-out governance. It was very tactical to make sure that as new data sources came in, they went through the chief data officer's review, and she could take a look at it, make sure that that made sense, that all the data use agreements were in place, so we weren't sharing data against rules and regulations or policies or laws, and made sure that all the the data was structured in a format that would make sense from a reporting perspective. And it also went through the Privacy and Security Office within DHHS, the PSO. Again, making sure that we were complying with all the rules around Medicaid data or different data types. And this data fell under both PHI and some other classifications that belong to the public health, the Division of Public Health, which classifies that data a little bit differently. So again, tons of rules and regulations surrounding this. So we used ServiceNow and built this a quick and dirty workflow within ServiceNow to manage these requests. We're still using it today, and Matt's going to talk a little bit more about how we're trying to evolve that into a little bit more what I would call sort of mature governance as opposed to what our tactical governance we put in early in place. I think the other thing we had to sort of think about, and where the chief data officers folks came in really handy, was there are really complex data use agreements and rules to share data between different organizations. Within DHHS and external to DHS, and it's going outbound and inbound to us. And we had to make sure all those data use agreements were in place and properly executed. And you get a little bit of a pass for public health emergencies, but at the end of the day, when someone comes and audits it down the road, you have to make sure that you've complied with all those rules and regulations. So again, making sure all those data use agreements and the legalities of all that were in place was also important as well. So now we have a platform in place. It's secure. We have some level of control of the data flowing into it and coming out of it. And we have all the legalities in place so none of us are going to go to jail if something goes wrong. And that's sort of how we got to the platform we have today, what we affectionately call BIDP 1.0, or Business Intelligent Data Platform 1.0. And I think Charles is going to talk a little bit now around what happened next.
Thank you, Ed. Appreciate it. Well, before I do that, I was finally waiting, and she's come in. So as Ed referenced, we built this platform, BIDP, within 48 hours. But the story started a little bit before then. We were, I guess, about 6 months prior to the pandemic. The state, we were very focused on whole person-centered care. Our secretary really wanted us to really focus in on if a person represents within Medicaid, are they in other silos? We're 32 divisions within DHHS, so we're a very large organization. But are they in Office of Rural Health, or are they in disabilities? Are they in mental health? Are they in our PDMPs, or any of these other areas which may give us a more holistic view so we can better assist our residents in North Carolina? So we were already struggling with the concept of how do we bring disparate data sources into one place to where we could really start evolving our clinical solutions to them. And Babita Savinsky, who is one of our enterprise architects, is here. And she actually came forward with the design. And it's the design that actually ended up being there. And we were just kind of toying around, was this the right path? Was there another right path? And then the pandemic hit. And then we had to have it. And in literally 48 hours, she stood this up. I'm sure there were others involved, but I didn't get that sense. I think she was doing most of it herself, but there was just a Herculean amount of work that she did as a public servant to make sure that we as a state were in the best position to support that. Now, one of the things that happened once we got the BIDP up and it was running, and we had the MVP up in 48 hours. Now we were starting to hit traction. We were starting to do some configurations. We were starting to bring on certain data cell elements. We were working on, for example, a project I did with the hospital automation project. We actually worked with all 132 hospitals throughout the state to make sure that what we said was an acute care bed. All of them agreed this is the definition of an acute care bed. And then we created an API for them to automate all of that data flow so that when we had a count of acute care beds, it was done on the hour, and every hour was changing. So if you had a hospital that was having a surge of COVID patients, they were running out of acute adult ICU beds, or they were running out of a particular kind of ventilator, then our system would know about it, our policy people would know about it, and they'd be able to react. That is all made possible because of Babita's work and the BIDP and what we had going on. So we were creating new data sources. We were taking advantage of older data sources. We were trying to make those older data sources better and make all of this work. And once we started really hitting our groove, we became victims of our own success. And there's a few things because Medicaid, the regular book of business we have, 32 divisions, a lot of people, they were also seeing that they were having problems conjoining data, normalizing data, making it presentable, putting it into reports, querying data. And so what they did, they saw what we were doing, and they asked if they could tag along. So you had a lot of regular book of business people that decided that, saw the value of what we were doing, and they wanted to join. But again, there was still just Babita. And there was a small team of people that were really doing this work. So it created a concern for us of how do we scale? How do we have the personnel to make sure we're scaling properly? Again, this is very, very privacy protected data. It's very secure data. So we have to be very cautious about who has what credentials to what data. And so it really forced us to really develop, as Ed was talking about, a strong governance process around it. It kind of exposed that in order to scale more, we were going to have to focus in on that. It also focused or helped us understand that things like that you see up there, cataloging, advanced automated governance, support of health standards for use as fire, were things that we didn't stand up within 48 hours for obvious reasons. It's the fog of war. We were going through the basic stuff that we needed. So in order to achieve that level of work, we needed to kind of pause and look and say, was there a different way we do it? We couldn't stop the work. We still had people coming to Vita needing a new data element added to that. So what we did is we reached out to a company called Amita, and asked them to come in and kind of do an analysis of what we were. What's our baseline here? Are there any gaps that we have? Are there any things that, new tools that we could bring in to kind of help us get to that stage? So that was kind of the next step that we were looking at. Is this working? Yeah. So Matt, if you'll take it over. Matt McCall represents a company called Amita, he's a co-founder of it. Was one of the key people that we looked at now going into the future. We've got the BIDP, we've got it set up, it's functioning brilliantly for North Carolina. It's giving all those reports that you saw daily, but now what are the things that we need to do to take it to the next level? And so Amita, if you don't mind, Matt, thanks.
Sure, thanks. All right, so as Charles just mentioned, in December of 2020, we came into North Carolina to take an evaluation of the current state BIDP and look at it and try to make some recommendations for, if you were going to take what was purpose-built for the COVID-19 response and expand that to something that could be used across all of DHHS, what do we want to do architecturally and operationally to get there? And so how this came out from our evaluation was 7 sort of gaps and then recommendations that we found. So the first gap that we've talked about was the numerous data sources, destinations, and integration patterns. So as I mentioned, the BIDP was purpose-built for the COVID-19 response. When you're doing that, you're integrating with a bunch of different data sources using many different protocols, right? So you have SFTP, and you're transferring files over REST, and it's all in different formats like CSV, and then you could have JSON payloads, and you actually, I think we used database migration services to actually just do database transfers of information at one point. So, and all the timing of that is different. So the complexity of those types of integrations that were purpose-built for the BIDP response, which again was the right thing to do because you need the data, you just go get it. We need to figure out how we can scale that as an organization because that complexity is going to just get more and more complicated as you add more data sources and different protocols, and the governance of that will be difficult. So that was the first thing that we wanted to talk about. The second thing that we identified is the data transformation logic was distributed. So upstream from the BIDP, you were having data transformations because the files were being extracted for the COVID-19 response. So there was logic in SAS, for instance, to perform extracts that were built for that. There's also logic downstream from the BIDP in Tableau. So in Tableau prep, the queries were being performed and data was being manipulated in ways that could be brought further up the stack, I would say, and help us reuse code and not repeat it as we start to think through how we can centralize some of this logic that we're using to manipulate our data. Bullet 3 here is a problem of bandwidth. So a single small team was supporting the BIDP, and this was a ServiceNow desk had transferred tickets to it, and you responded to them as they came in and were prioritized and worked through that. Well, if we're stepping back from the COVID-19 response and thinking about how this would be scaled across the organization, that doesn't really work for trying to support all the 32 divisions that Charles just talked about. So what we want to think about in that situation is how we can sort of federate and scale out from a business operations perspective how the data can come into the platform and be governed in the platform. And that sort of ties into bullet point number 4 here, is that if we want to start getting people on the platform and using the platform more than it's being used today, there's no way for analysts or people from across all of the organization to figure out what data is actually in the platform without running SQL queries or asking somebody, and you wind up relying on subject matter experts, and their knowledge is tied to the database structures, and you can't really do self-discovery for analytic purposes. Our fifth finding was Tableau was the only reporting tool. So as the BIDP was rolled out, North Carolina went with Tableau because Tableau is what everybody knew, and we need to get something out the door quickly. But from an enterprise operations perspective, there's all sorts of tools that we can start to think about. For instance, Microsoft Power BI could be being used by one division that wants to integrate data from this platform into their current operations. If they really want to, someone could use Excel to do extracts from the BIDP and do operations that way. So thinking about what we could do besides Tableau on the platform was an important thing for us to identify. Number 6 was in response to an operational challenge. So I think as Ed mentioned, the Go Anywhere MFT is how files are coming into the BIDP. That was actually owned and operated by a team independent of the BIDP support team. So the maintenance operation schedule of something that's critical in the processing of information coming into the BIDP wasn't something under the purview of the team that needed to support it. So figuring out how to bring those critical operations in-house will let you make sure that you don't have a miscommunication and suddenly your MFT server is down and you don't know why and you can't figure it out without having to go talk to somebody. And then number 7 is really about resilience. So the dashboard is a publicly accessible asset that everybody in North Carolina uses. I live in Los Angeles and I use it. I used the COVID analytics every day to figure out like what was going on with case rates and how comfortable I felt like being in store, and everybody needed to access this thing. So if it goes down for an extended period of time, we really need to think through what that looks like. So a 3-hour outage versus a 5-minute outage is a very, very big difference in terms of both people's confidence in the information and architecture that you're putting up there, and in making sure that all the information is available so people can use it in their daily lives. So what we needed to think about was resilience across AWS regions and not just availability zones. So if US East 1 went down, how do we fail over, what do we bring up, and how do we repoint all of our assets? So the recommendations that we made to North Carolina come out here. And so these are the things that we want them to think about moving forward. The first one of which is land all source data as files in S3. So if we can think about the BIDP as an enterprise-wide asset, right? We want to start thinking about landing all of the data in exactly the format that it came over the wire in an S3 bucket. This is for a few reasons. One, it prevents us from making assumptions about the data in our integration patterns. So if you're running a query from a source system and putting that into a relational database directly, you have to make assumptions about the schema, and if it changes upstream, it breaks your process. If you just pull the information down, dump it into a file, then you can run sort of a late binding process, and that won't inherently break it, and you can sort of diagnose and understand it, and that's very valuable for an attribution and reporting perspective in terms of logging information that's coming in the platform. This is also what we're seeing a lot in the industry in terms of an approach to data lakes. So if you're pulling in data and it's in a structured form, you can overlay something like Apache Parquet or Delta Lake on top of that and do queries directly into those files to get at the raw information without having to kind of curate those assets into a relational database store. So as we think about empowering analysts to do advanced analytics on this information, thinking about how we can get them information access quicker and further upstream in less structured ways is important. And then finally, by landing everything as files, we can enable some of the use cases that Charles mentioned, the faxes coming in. So if we need to run optical character recognition on faxes and bring that data into some sort of structured form, landing everything as S3 enables us to do that pretty easily. The second recommendation was we should look up and downstream for our data transformation logic and consolidate it where we can. And this is sort of a governance point, but if we're going to have different ways of transforming data at different points, we should be thinking about best practices in that process. And as we think about governing our data, centralizing those best practices as part of that process is something that we could do. So we could implement a shared GitHub repository and share code assets and have best practices for the way that we do things around that. So architect for federated data governance and implement data curation support tools I would talk about in the same hat. So the Chief Data Officer's office implemented or designed several data governance processes and roles, including data owners, data custodians, and data stewards, and thought through a lot of how organization-wide data governance would work. At the same time, tools can be laid on top of the BIDP that would enable you to implement those capabilities and those flows as part of your business operations. And those tools are effectively data catalogs. So we kicked the tires on a few of them. We looked at Dell Boomi Data Catalog at Prep, Elation and Calibra as possibilities that we could use working with the CDO and overlay these on top of the BIDP to sort of distribute governance and federate it across the organization. So as data sources come in, we identify a data owner who isn't one of the core people working at that service desk, but is actually an owner from the business unit, and bring them into the process so we can help develop organizational buy-in and distribute the workload for management of information on the platform. Own critical system components I talked about already, making sure that none of the things that are in the critical path are owned by anybody outside of the process. And then planning for high availability and disaster recovery. That was the development of a multi-region failover strategy for the BIDP that we wound up developing some CloudFormation scripts for and handing over to DHHS so they could get their RPOs and their RTOs up to where they wanted them to be. And then my final point here is enable additional analysis and reporting tools. So as I mentioned, we could add other tools besides Tableau. We could add a Microsoft Power BI and let other tools such as that or reporting suites lay on top of the BIDP and access that data. But we could think about tools beyond that. So when we think about enabling analytics, we looked at Databricks and additional tools like R or MATLAB or whatever you would want to do on top of the data you could enable. But from an analytics perspective, where we really want to get to is not just a reporting capability, but a predictive capability. So as we identify cohorts and populations for intervention, we're actually trying to figure out who the most at-risk populations inside of North Carolina are. And by giving some of these advanced analytic tools access to raw data on the platform, we can start to develop these capabilities as DHHS. So that's effectively what Amita recommended to grow the BIDP 2.0 into an enterprise-wide platform, and we passed those recommendations on. And we actually demonstrated them a couple times to the organization. So we conducted a series of, I'd say 2 proofs of concept. One of them, the use case was a mother of a single child who had developed COVID-19, and the type of information that we could gather from her, information that's across the organization. So we could figure out from the lab test results coming in that she had gotten diagnosed with COVID-19. We could look at her Medicaid claims information data and understand that she received monoclonal antibodies as a therapy. We could also look at her eligibility for SNAP and WIC or heating assistance and develop a better picture of what this individual was and understand how we could engage with them more appropriately. Outside of COVID, we talked about how developing an idea of a better view of an individual is something that the BIDP could support. So we developed a use case for a foster care child who was being prescribed 4 or more psychotropic medications. This is something that is a red flag criteria for the state because if you're being prescribed that many psychotropic medications in a child, sometimes that's being used as a chemical restraint and those drugs aren't really necessary. So you really want to identify those individuals for proactive intervention. And you can do that through claims analysis and understanding if that individual is also enrolled in foster care. And so there's some real power to identifying data combination opportunities across the organization. And that's what we demonstrated with the tools and capabilities that we put together for Charles and his team. Thanks.
Thank you, Matt.
You're welcome.
Appreciate it. One of the saddest, I don't know if you want your water or not. Stories that we got from that was what he just talked about, the foster child with 4 or more psychosomatic drugs they could be taking. The scariest part of clinical work with a child or somebody in need is that the data isn't speaking to the other data sets affecting that individual. Our goal here is to create a unified view of individuals throughout the various silos that their data sits. We don't want to mess with the data sources. The data sources are what they need to be, but we need to bring in a place where we can actually see them and give them a better view. So we appreciated Amita's view on this. The BIDP was our first real entry into that space of bringing disparate data sources into a common place to view it. But as you mentioned earlier, it was a COVID-specific response. The enterprise capability for it is what the state is moving towards next. So this is, for me at least, the sexiest slide you're going to see at AWS because it's so full of information that it's just fun to think about what the future of DHHS in North Carolina looks like. And then what I would challenge everyone is what the future in your states or your companies or wherever you are, where you should push in this direction. So one of the things that we did was the challenges of data sharing. So we finished a project with our Chief Data Officer, Jesse Tenenbaum, worked with an outside consultant. They came in and they actually worked through with our attorneys all of the DUAs and all the MOUs that we need to set up for data sharing within a 32 division organization. It's a mammoth organization. And you can imagine that there used to be, like DPH used to be its own organization. Now it came into DHHS. There's probably a little cultural resistance to that. So maybe they're not as open to sharing their data, or they're a little bit confused about can they share this data or that data. I think Medicaid's another example of a place where should they come in and share their data in certain sets. So by spending the time of working through the legal definitions of that, we were actually able to really kind of set up this data sharing rules across the enterprise. And by doing that, now you've taken the responsibility off of that individual person who is maybe taking care of foster children. That's their job. Their job shouldn't be deciding whether or not that data set can be shared with that specific individual who's in that other division. That should be handled by a legal framework or a governance framework that they just plug into, and that responsibility is off them. We need to get them back focused to the job that they have. So that was one of our biggest challenges that I think we're in the process of finalizing that. We've really gone a long way into it, and I'm very excited about that part. You've heard a lot about converging old data platforms with new data platforms. So I mentioned the hospital automation project. That was one where we got 132 hospitals to send into a common API. We worked closely with a company called Apris. If you've heard of them, they're now Bamboo Health actually, but they handle all the controlled substance reporting systems throughout the country. They pretty much have almost all of them. There's a few states that they don't, but that's how we knew them. They came in, they offered, how can we help during COVID? We put them on this task. They created a universal API. These hospitals sent them to, usually on the hour. So we were getting updated information on that, and it was coming into the BIDP. So we were able to generate a lot of reporting. But all that was taking these older systems, moving it into a newer system, and now we're combining that with these arcane lab reporting systems, for example. Now we can start comparing lab results and where we're getting our lab results, who's getting tested and whatnot, in what regions, and what the hospitals are impacting, and what kind of relevance or comparisons between those data sets. So these are very old systems that we're merging with newer systems. It was very exciting to see some of that work, but it was the BIDP that made that possible. This one was really tough, the cost allocation piece, because as I mentioned, we had Medicaid. Medicaid is governed by CMS, or not governed, but they receive a lot of their funding from CMS. And DPH receives some funding from CDC. So we had, and whenever you receive funding from a federal source or through a grant or something like that, they have their own rules, right? They have their own guidelines. This is how you've got to spend the money, or this is how you've got to report things back to us. So we were able to generate a lot of healthy reporting out of the BIDP, as well as the COVID vaccine management system that sent up to validate a lot of the work that we've been doing with the CDC and with CMS, so that we could start pulling down some of those funds. Because while the BIDP is not a crazy expensive platform for us to have, it does cost. And it's a new thing, right? So there's not like a general appropriation for it. So what we had to do was find cost allocation plans through all of our different federal partners or grant partners or whatever, so that we could start building out the support for the BIDP and maintain it. And then fourth, and you've heard a lot about this, is the governance that works. I can't underscore how important this is. If the number of times, I think Babita stopped accepting my calls after a while, because I would call and say, hey, we need to get this data set through, which meant we're bumping something else out. And it was such a thin work through. We had tickets through Salesforce, but then that was it. And so we needed to set up, or need still, to set up a stronger governance and really combine some of that step one process of data sharing with a lot of the governance of the actual platforms that we have going forward. And then the number 5 is, I don't know, to me, this was the most interesting part of this, because frankly, you had a lot of governance, or a lot of data within states that you had people kind of say, all right, we have this many beds available. But they really kind of stick their finger and kind of check the wind a little bit and go, yeah, it's about 80% accurate. I bet it's about, we sent a survey out. Someone maybe didn't come into work that day, so they didn't turn in those results from a particular hospital, and maybe that's a large hospital, and so we didn't have that view of that particular bed count in there, or they get in later in the day, and by then time, you've already made some policy decisions. So I remember at one point when I realized this hospital data in particular was coming through and that we were going to present it to our policymakers very quickly, I remember challenging the group, and we had the whole group. It was about 100 or so people in our COVID response, including the secretary. And I challenged them by saying, look, you're going to receive data that you've not received before. You're going to receive data that is not 80% accurate, 90% accurate. It is 100% accurate. And that data is going to be changing on the hour. So that starts shifting accountability, because as an organization, now you've received 100% accurate data, and it's changed. So if a hospital is getting overrun with COVID patients, and they're running out of hospital beds, and they're looking at some release valve, the state has now, because we know this, because the data's there, now we have an obligation to actually solve that problem, or work with the hospital to solve that problem. That's a different level of accountability that most organizations aren't used to. And I can't even put that on just governance. I mean, the government organization, I think that's most organizations. When you start really kind of putting in these types of tools and making data available from the source to the display, now you've shifted accountability to the people and the policy leaders. And so that's a conversation that I would challenge all of you to not be quiet about. You need to speak up when you get those opportunities to speak with the policy leaders who are going to actually ingesting this data. And then the last bit here is the siloed data. We have some divisions that either because, I don't know, they've been the tip of the spear for 2 years, they're tired, they're exhausted from change, or they have so-and-so has always been responsible for governing that data, and they really don't know the new systems, so they don't know what they can share and what they can't share. They just know that they'll get in real trouble if they make a mistake. And some of this data, like mental health data, foster care data, child welfare data, if one of your tests come back for a virus or a communicable disease, all of those tests, all that data is entrusted to these people that traditionally have maintained it by saying no a lot. They know you can't have it. That's not there. It's siloed. I'm protecting it. I'm in charge of it. We need to release that from them because A, that's too much responsibility to put on an individual. That's a law that's passed in your General Assembly. That's a support for HIPAA or NEST or one of these other requirements that we have. We've got to set those standards in place so that they're automated, so there's a gate check that an automation will catch, and so that an individual is not born with that responsibility to bear. So that reduces a lot of that siloed data. And the last thing on top of the siloed data that you're going to have to focus on, or that we spent a lot of time with, we worked with SAS. You may be familiar with the analytics company SAS. They're based out of Raleigh, so they're in our backyard, and they were able to be very helpful for us. But we developed something called a master patient index. A master patient index is a wonderful tool that allows us to track individuals, assign a code to them, and be able to track them through different areas. It's a very difficult thing. I heard someone kind of breeze by it in another presentation earlier yesterday, but this is not something you can breeze by. It's a very complicated thing, and it's something that you get better at as your algorithms get better, as you're able to track things and your systems work better together. So we've been spending a lot of time on MPI, on making sure that we have a way of identifying individuals and identifying throughout the process in a very discrete way. So those are some of the key areas of growing pains and lessons learned that we have, both culturally as well as technology-wise. And you can't, it doesn't matter if the technology works if the culture isn't going to support it. So you need to spend a lot of time with the culture within your organization just to make sure that your technology, you can't just flip the switch and expect that culture to support it. All right, so as I mentioned early on, when Secretary Cohen and Governor Cooper set us out on a course to remove the drama around COVID. A lot of people were scared. I think we all were scared at some point. Where do you go? Can you go out there? Can you go to that restaurant? Can you see your friend? Can you go home for the holidays? Do I have to wear a mask when I see my family? If I'm outside, just the rules, what were they? Especially in March of 2020. It was a scary, scary time for us. And one of the things that really kind of resonated with us is set a standard, be transparent, make sure that all the systems that you're setting up allow you to maintain that transparency and that trust with the residents of North Carolina. We worked hard to build that trust. And as you recall, and I'm not trying to get political here, but the national conversation was just not building trust in the same way. There was a lot of confusion, a lot of statements that weren't true being made. It was just a confusing time for people. And so states, in North Carolina at least, residents were able to look at our website. And that's why you saw, 18 million hits in a month, more than those websites have been hit in 2 years combined. And that was all in 1 month. And that was happening over and over and over again. So we needed to build that trust. As Ed mentioned, the media would call us if it was 5 minutes late getting out. We finally got to where it was automated and it was just generating on a regular. Daily news conferences, Secretary, Governor met daily, and we're speaking to the public. We were working off of the data that we were presenting. In fact, we had actually a data dump day, we called it, and it was just that day where all this new data came out and they explained it and walked through it. That was our guiding principle and something that I would recommend for anyone who's considering doing this kind of work. And then the ability to consume multiple data types is a new concept for, in our case, all of our divisions. They're used to controlling their own data. They're not used to working with other data sets and kind of bringing all those together. And so you really need to think through what that means for your team to make sure that culturally you're bringing them along with that piece. And then, as I mentioned before, the faster, more real-time data to support operational reporting. This has really caused a lot of divisions that were doing a lot of manual work, combining Excel sheets and copying and pasting and getting sum totals, to really look at this as, my God, this would be so much better. So whereas we were getting resistance in the very beginning to this concept, I remember the day when a person who was particularly resistant to doing a BIDP came to me and said, hey, is there a way we can use the BIDP for all these data conjoining efforts that they had? And it was a great day for us because it was like, yes, the model proved right and it worked. So we were able to really kind of, and it's just growing. Every day there's more and more people that want to use it. And then the last thing, kind of what's next for us. We've obviously done the enhancements. We've changed a little bit of the culture within a large operation of 32 divisions. We got 3 mental hospitals spread out amongst the state. We're a large state of over 10 million people. We've got a lot going on. And we were able to kind of demonstrate enhancement of data and then start doing very targeted rollouts of what we're trying to achieve. And in order to do that, after the targeted rollouts, then you get to the business adoption, where you're really kind of bringing people in. The last piece is where we're going next, and that's the enterprise rollout. So we will be coming out, and this is the part I have to be careful about because, RFPs and so on and so forth, but there are things we're going to be coming out with that will be hopefully a lot of great vendors will be bidding on as we look to take the BIDP to kind of a version 2, which is an enterprise view of all 32 divisions, where all of the data governance, the rules are clearly defined, who can access what data is automated through a process. We're able to use and stand up containers quickly to make sure that we're doing proper storage of data, that we're highlighting our security, that we're really focused on promoting good quality data maintenance. And we're actually able to give, we call it healthy opportunities as an example of this, but it's really social determinants of health. We're actually able to see an individual who just life is getting in the way. They've got so many issues that keep hitting them over and over again. We're going to be able to start seeing that view. How do they come into our system? What's a better way to clinically deal with them? Right now we have, as every state does, I think, we have children who are either foster children who are in our emergency rooms because there's not a mental health place for them to go. This is one of the most heartbreaking things for me to think about. And these people are using the system. There's so much money going to such a small number of people. And that means two things. A, we're not spending our money wisely. But B, we're also not helping that individual. If they end up being in the emergency room and that's where they are because they're a minor and they have mental health issues, that's not the proper place for them to be. These types of platforms, this platform specifically, will give us the ability to see that person and better clinically treat that person. That is our goal. That's what we want to get to. And it's going to take us a little bit of time to get there. We still have some cultural resistance to sharing that data. But when we finally get there, it's going to be a brand new day in North Carolina. And we're going to be able to really assist people and help people get managed through their life so they can get to a place of self-sufficiency in some places. It's just going to be an exciting legacy type of moment for all of us. So that is our time today. We've got about 8 minutes left. I'd be more than happy to answer any questions from everyone. And I do want to thank Ed and Accenture and Matt and Amita for their incredible assistance and taking the kernel of an idea that we had as a state and that Babita was able to stand up in 48 hours and really take that kernel and grow it into something that's even bigger than we had imagined. And we're just very excited about the future of that. But we'll be glad to take on any questions if anyone has any for us. Mm-hmm. Certainly. Well, I think, that's more of a federal government type of question, and they try to do that in some areas. I think you saw a lot of like the dashboarding for the COVID response at a national level was getting a lot of the data, like I mentioned earlier, we reported a lot of the data up to the CDC. Certainly the case counts, we reported all those things up there. So they were the target of a lot of the data that we had. They would put it together and present it in their dashboards. This is where you could really start seeing the discrepancies between the work we were doing in North Carolina and some of the other states that were out there, in particular on like hospital bed counts, ventilator counts, those types of things. I mean, we just went from, we had to actually explain them when we turned the switch on this, that we moved from a survey to a fully automated system to make sure they knew that, yeah, your data is changing today. So that is really the job of the federal government. They do some regional activity for that. They break down all that data into regional areas to kind of get that view. And I know our governor and secretary are they're in constant contact with, in our case, Virginia, all of the states that border us, the Georgia, Tennessee, South Carolina. So yeah, I don't know if you have anything to add or if that's.
Yeah, I do think that states in general do a very good job, especially with federally funded products, in sharing across borders. I know what BIDP is not an example of that. I know that North Carolina has taken assets from other states, Virginia, for example, and implemented them in North Carolina and saved a boatload of money, as opposed to going out and procuring something from scratch. So I do think there is a good amount of sharing of both information, knowledge, and technology to some extent across borders. So I think that definitely does happen.
Mm-hmm. I know we're in the process to that point of the Medicaid enterprise system we're currently doing, where we have this big monolithic Medicaid system. It's our fiscal agent for Medicaid. We're actually transitioning that out, create a series of modules that attach to a single system integrator, so that you can switch out the modules, or as the contracts run out, you're not wedded to one big system. You can break them out into smaller ones. So we're in the process right now of doing that. And that's an example I think he was talking about, where we actually were able to take the base code of the encounter processing system of Virginia's, bring it into our state, and we're special like every state is, but we had to configure it to meet our specific needs. I think we're looking at NASIO as another federal program that allows you to go out and procure another module that's been already procured and gone through the process in another state. So it lets us cut down some of those steps. Any other questions or comments?
One in the back there.
I'm sorry, I didn't see. Okay. So cost allocation wasn't based primarily on the federal funding for COVID. The cost allocation really gets into like CMS when they do their 90-10 federal match or 75-25 on base Medicaid programs, like the modules that we're building out. If we're going to use this platform for data integration, or to get a reporting function, we call something like NC Inc., or one of these functions that needs to be reported up to the federal government, that is where we would identify this for cost allocation purposes. I know the CDC does a lot of grant work, and so through that, have assigned within the grants the use of the BIDP for that, and so some of those, that's where the cost allocation came in more for us than the COVID funds, unless you have misrepresent that.
Yeah, and I think you also mentioned, Charles, earlier on, at some point in time, there'll need to be some type of funding mechanism to keep the BIDP solvent, so to speak. So whether or not it becomes chargebacks by use or something like that, there's going to have to be some type of model in place to actually fund the platform as it goes enterprise-wide, DHHS-wide. Right.
Yeah, our thought was, it's almost like a toll tax or something like that, because at the end of the day, it's such a good platform that people have just said, hey, I want to use it too. And while we're opening the door to anybody, we also realize that there's a cost to that. And so we're going to have to start setting up what that toll cost is going to be. But the more people using it, the less it's going to need. So that's kind of the model that we're looking forward to.
Nice thing about the platform too, on the scale of things, it's cheap.
Yeah. No, it's
compared to other products that either in private or public sector. So it's really inexpensive.
It is. It is. Mm-hmm. Yeah, we put her in bubble wrap and send her out and make sure that she's okay. No, this is the real problem for state government. I mean, we have resources that are really tied to state budgets, and they assign those budgets to a specific code, or usually an O&M type of thing, versus a kind of modern system. I was telling people, while it was COVID, it's probably the best time to work in state government, because you had to move quickly on things, but B, you also had a lot of money to spend on things, and you were asked to spend it quickly. That is not the norm for us. It's actually just quite the opposite. So what we're having to do is look at how do we resource the BIDP in a way that allows Babita to take breaks and go on vacations and things, and not put ourselves in the jeopardy that you just described, because it is a real concern for all of us as leaders. You try to figure out and then also the talent. We're now setting up a process to retrain people because all these new platforms have new certifications. The AWS cloud certification process, trying to get our team to kind of move through that so that they can be trained to support, and then working with our DIT partners who also really host the contracts of the cloud for us to be able to use those things. Well, we are at time, 3 seconds early. So, thank you, both of you. Thank you, AWS. And thank you for your time today. We'll be around if you want any more questions. So, thank you.